Thank you, sir. Respected judges and friends, good morning. Our study presents a fail-safe technique for management of posterior polar cataract. No financial interest to declare. When we search the literature, you can see that the PCR rate, posterior capsular rent rate during cataract surgery in posterior polar cataract varies between 7.1 to 36%. And a number of surgical techniques have been described for improving the surgical outcomes and reducing the rate of complications during surgery in posterior polar cataract. We did the study to evaluate the safety and efficacy of phacoemulsification without any hydro procedures for the management of PPC. It was a single center study conducted on 81 consecutive cases of posterior polar cataract that underwent phacoemulsification. And the postoperative data included record of any intraoperative complications and the corrected visual acuity at 3 weeks and 3 months. Sorry about that. In all cases, it was a temporal clear corneal approach. No hydrodelineation was done, and no mechanical dissection was done. So soon after the capsular excess, phaco was initiated. In cases in which chopping could be done, direct chop was done, and once that was initiated, the nucleus was actually rotated, and the nuclear material and rest was fed into the phaco tip. Here you can see the posterior polar element getting into the phaco tip along with the epinuclear plate, and at no point during the surgery, the intracapsular pressure was allowed to fluctuate. So, and you can see the pseudo hole at the end of the surgery. This is a very soft cataract, and immediately after rhexis, the phaco was initiated. This is a very soft cataract, and in such cases, the chopping can't be done. And here the chip and flip technique was employed, and here again, the nucleus was rotated and fed into the phaco tip. And here you can see most of the posterior polar element getting into the phaco tip, and you have a bit of the posterior polar element stuck to the PC. It is very dangerous to polish vigorously here because you'll definitely get a PC rent here. Just peel it off, and whatever remains. And so this is another case of posterior polar cataract with the pre-existing posterior capsular rent, CPCD, the congenital posterior capsular dehiscence. Here again, it is a very soft cataract. Direct chop could not be done, and it is again a chip and flip technique. Again, you can see the nucleus being rotated into the phaco tip, and the whole posterior polar element coming into the phaco tip along with the epinuclear material. And again, it was made sure that the sudden variations in the intracapsular pressure was avoided, and so that's the end of the surgery. And so in none of our cases we resulted in posterior capsular rent. 2 cases had CPCD in which there was neither enlargement of the defect or no vitreous disturbance following phacoemulsification. 2 cases developed PCR, that was during corneal wound hydration. However, the intraocular lens remained stable and well-centered. The mean postoperative logmar CDVA improved from 0.6 to 0.04 at 3 weeks, and it remained same till 3 months. So hydrodelineation and other dissection procedures are done during phaco to facilitate the manipulation of nucleus during phaco. It is a rise in intracapsular pressure during this procedure that causes the rupture of an already weak posterior capsule, and this has
Can you repeat this slide again?
manipulation of nucleus during phaco. It is a rise in intracapsular pressure during this procedure that causes the rupture of already weak posterior capsule, and this has to be avoided to safeguard the posterior capsule. In 2 cases in which PCR developed in that study, it was because the anterior chamber was tightened too much and caused increase in intracapsular pressure. In a study, no hydro or mechanical cleaving was done, eliminating the possibility of intracapsular pressure rise. Masuda et al. Showed that mechanical rotation is quite effective in mobilizing nucleus for emulsification in normal cataract cases. Our technique also used mechanical force to mobilize the nucleus, though unlike Masuda et al., our technique, the nucleus rotation was performed after the emulsification chop was initiated. So to conclude, phacoemulsification without any lenticular cleaving procedures, including hydrodelineation, is a very safe procedure for managing posterior polar cataract. Contrary to the conventional teaching, if the stress on the weak posterior capsule is prevented by avoiding rise in intracapsular pressure, nucleus rotation can safely be done, performed during phacoemulsification in PPC, even those with the congenital posterior capsular dehiscence. Thank you, sir.
Very nice presentation, Dr. Srini. I had a question for you. How difficult was it to rotate the nucleus without doing a hydrodelineation?
It is for those grade 2 and above, it rotates. See, it's what there is in our mind that you can't do phaco without. So, I mean, after it just happened in one case, I just did this. I thought it can be done, and now I'm actually trying it out in normal phacos, like Masood et al. It rotates. See, initial few cases in the grade 1, I couldn't actually do it. That's there in my this thing, and in those cases, that was initially before I got a hold of it. In those cases, about 10 cases or so, I had to move superiorly because I couldn't get it from there. But once I got used to it, now I'm able to rotate and manage all those cases. See, everyone says, all studies, see all papers, don't rotate, don't rotate. But see, if there is a chance for it to fall down during this thing, it is like the third grading of Dr. Vasavada. It will be spontaneous
And
dislocation.
another thing is the epinuclear shell, which we ideally create with the hydrodelineation, would act as a cushioning factor.
Yeah,
which
exactly.
are-
That is
because there is no cushioning factor. Don't you think the risk is even higher?
no. That is what I want to see. The hydrodelineation is not a fail-safe one, and hydrodelineation procedure itself is increasing in
No,
intracapsular
if
pressure.
you press on the posterior lip initially, I mean not so much, so how much increase in the intracapsular pressure you create is up to you when you're doing the procedure. It's just a thought.
No, yeah, I
something
understand,
new.
but there is a possibility. See, why Dr. Vasavada went in for you do a bowl and then do the hydrodelineation was because see there is a chance that fluid might escape and you might have a bit of hydrodissection happening during hydrodelineation. I mean, I know all of you are wonderful phacosurgeons, but in everyone, there is a possibility that it might escape. And my point here is that, so I have to have some model to show that it is that intralenticular pressure, intracapsular pressure that we are creating by all these procedures that is causing the very weak posterior capsule to rupture.
What intraocular pressure you maintain while doing phaco in such cases?
Sir?
What pressure you maintain while doing this bottle pressure which you maintain while doing such cases?
So I mean, I don't have a Centurion with me. Normally, I do at 106 centimeters on my Signature Pro. So I keep it down to about 95, so that this thing is a bit.
So what we have learned from you, it is something different from the classical teaching. Now tell me one thing. When we do polar cataracts, we are very gentle. Whatever procedure we do, hydrodelineation, we try to be most gentle.
As
No?
possible, sir.
So when you are putting a pressure of 95 with your machine, I don't think that your purpose is solved, because in your slide you told that because you are managing it, you are lucky to manage in so many cases, but many times we can land into problems, we can land into mishaps.
So that initial one, it's generally in the anterior chamber and it's not really located into the this thing. So I mean, I take your point, sir. It is not, the pressure inside is not that great.
You are saying that you are not doing hydro procedures, hydrodelineation, because you are afraid of increasing the pressure. Then again, you are just contrary to that, you are putting a bottle pressure of
No,
95.
without bottle pressure, I can't have a AC there. It's like what normal
There's one
intraocular
more
pressure.
question. You've done everything fine, but what I want to understand is why did you not do a mechanical separation of the anterior?
So I've tried. See, that is my point. That is my point, sir. You don't require a mechanical separation even. So that
No, the question is not whether you
No,
require
that's
or
fine,
not.
that's fine,
It
that's
would
fine.
make your life simpler actually. You are not increasing the pressure in the bag, and also you have reduced the adhesions, so the rotation becomes simpler actually.
Yeah, exactly, sir. See, that is another point in this thing. Even that is not really required. That is my point. Even that is not required.
Okay, thank you.
Thank you.